ClinHaem, Hematology, Demystified.
Defining and Diagnosing Haemolysis. Part 1 of 4 from ClinHaem's FRCPath Masterclass Series on autoimmune hemolysis.
So welcome again. This is Husnain. I'm one of the hematology ST7s currently working in West Yorkshire, and I will be trying to help you with this topic today, which is AIHA and ITP, which is the first topic in the series of sessions that we plan to cover in our attempts to be prepared for FRCPath Part 1 exam of spring 2026 or later. Um, yeah, as you can see, there are two topics. I would start with AIHA, and this will be the layout of the top of the talk. So I'll start with pretty basics because I know some of the actually many of the colleagues that have registered interest for the course, they are just starting their hematology journey. So I know some of you will be quite senior and experienced, but I will try to start from the very basics so that those who are new to the field can you know get the most of it as well. So yeah, I'll start with how do you define hemolysis and how do you diagnose hemolysis? What's the differential diagnosis? Then the diagnostic approach, including a few slides about direct Coombs test, and then causes and the serological subtypes of AIHA. So if you are quite senior and you can probably sleep through this bit and the bit afterwards, but this bit is the one in red is the one that confuses us the most, but not but it is very important to diagnose the exact subtype of AIHA because treatment depends on what subtype it is. And also, it's very important for exam, and it can easily be a part of a long essay question. Has appeared in the past as well, of course. So I'll finish with some transfusion related aspects in AIHA and management, and followed by the references that I've mainly used for this presentation. So starting with the definition, hemolytic anemia is anemia that results from shortened survival of circulating red blood cells due to their premature destruction. Normally, red blood cells, they live for around about 120 days. They get old, and old cells are fragile, are unable to pass through the tight, passages in the spleen, so they are taken up by the macrophages. So that's normal. But in hemolytic anemia, even the fresh, young, healthy red cells are also being destroyed, for example, in the spleen by immune mechanisms, or otherwise, if there are other mechanisms like a metallic heart valve just causing their rupture. So they're being prematurely destroyed in the body. So autoimmune hemolysis is, of course, decompensated hemolysis that is autoimmune. So a body would develop an autoimmune response against one or more of the antigens that are present on the red cell, and that would lead to autoimmune production of autoantibodies, and that would clear these cells, causing breakdown either extravascularly in the liver or the spleen, or intravascularly within the vessel itself. But autoimmune hemolysis is a collective term incorporating lots of different conditions, which we hopefully will unpack today. So autoimmune hemolysis is not the diagnosis in itself. It's like it's a collective term, so you have to differentiate what exact subtype it is as a hematologist. So starting from the basics, as I said, to diagnose hemolysis, we do the hemolysis screen, and that's what you would have advised so many of your junior colleagues over the phone. The question comes, this patient has got anemia. Is this hemolysis? You say, do the hemolysis screen. What we mean by that is a list of tests, which are, of course, the full blood count, but the reticulocyte count, blood film, LDH, LFTs, haptoglobin, and the urine. Now, full blood count, of course, because you will see anemia in there, but there are some other markers that would help. Reticulocyte count is very important. There are only a handful of things that will give you a raised reticulocyte count, hemolysis being, of course, one of them. But, recent bleeding can give you a raised retic count. Recent replacement of a hematinic deficiency like B12 or a folic acid can give you a raised reticulocyte count, and erythropoietin replacement can give you a raised reticulocyte count. Blood film is the most important test in any scenario in hematology, and this still stands true here. LDH, so red cells are bags of this enzyme, which is LDH, and whenever red cells break down, they will release LDH. So it's quite a sensitive marker for hemolysis. LFTs will, of course, show raised indirect or unconjugated bilirubin because bilirubin is a byproduct of hemoglobin, breakdown. Um, Haptoglobin is a protein that's job is to carry free heme in the blood. It's because free hemoglobin is actually toxic to different organs. So to prevent that organ damage, we have got haptoglobin and some other proteins actually to help carry free heme and prevent it from thus causing any damage. Urine dip and microscopy is actually very important, so especially for intravascular hemolysis, and I will mention what to expect. And urine for hemosiderin again. So hemosiderin is so if there is intravascular hemolysis, which we will come to, which means that the blood cells are being broken down inside the vessel, so that will release free hemoglobin into the circulation. That will, the hemoglobin that's, you know, so it was the free hemoglobin will saturate the haptoglobin, and that's with the amount the hemoglobin that's above the saturating capacity of haptoglobin, plus the small, monomers of the breakdown product of hemoglobin, the small chains, they would filter through the kidneys. They will be taken up by the proximal convoluted tubules, and they will try to degrade them. And the iron that's in there, they will try to store them as ferritin first, and then ferritin will aggregate and then have some reactions on it to convert it to hemosiderin. So that's the breakdown product of ferritin combined together. That's hemosiderin, and that's how they will be deposited in the kidney cells. Now, if this process keeps on happening, of course, the kidney cells would shed that in those old cells into the urine, and you would see, along with them, hemosiderin in the urine. So what to expect in hemolysis? Of course, if full blood count would show low hemoglobin, it might show a raised MCV, and one of the reasons would be that reticulocytes are bigger cells compared to normal cells, so the overall mean corpuscle volume would be increased. Of course, you will see a raised retic count in hemolysis. Blood film might show polychromasia, which is suggestive of reticulocytosis, and you can see spherocytes in warm hemolysis and agglutination in cold. LDH, as I said, will be raised. LFT will show raised unconjugated bilirubin. Haptoglobin in hemolysis, the expected finding would be that it will drop, of course, because when it will be the used up to mop up the free hemoglobin, and haptoglobin hemoglobin would be the combination would be cleared by the liver anyway, so it will result in low haptoglobin in hemolysis. So urine dip would show it would be positive for quote unquote RBCs, but when the sample is looked under the microscope, there would not be any RBCs. So that's the hemoglobin that's the dip is picking up as RBCs. So dip positive for RBCs, but no red blood cells in microscope is expected in intravascular hemolysis. And urine for hemosiderin is present in chronic intravascular hemolysis, as I've explained, and that is quite a good marker for that. 1 week of intravascular hemolysis will give you hemosiderin. So if the intravascular hemolysis is acute, you will start seeing urine dip positive for hemoglobin without any red cells on microscopy. But if it's chronic, goes on for like at least a week, then you will start seeing hemosiderin. So if you see hemosiderin in the urine, that is an indicator that there is chronic intravascular hemolysis going on here. Having said that, uh, none of these tests is specific for hemolysis, and there are lots of caveats. So I will try to list some of them here. So FBC can actually have a normal hemoglobin even though there is hemolysis because it could just be compensated by the body. Or of course, the low hemoglobin could be from other causes as well. So can't just say this is hemolysis. Retics, as I've explained, they can be raised from lots of other causes, but um, can actually be low as well, even when there is hemolysis. So say if they have concomitant folic acid deficiency or B12 deficiency or parvovirus infection, or other causes for bone marrow infiltration. Now, folic acid can actually be used up when the hemolysis is quite severe because it's like a raw material that you need to make up more cells. And if the turnover is quite brisk as it is in severe hemolysis, you will use up the folic acid, and that can give you, low retic count as well. Polychromasia can be seen in bleeding because it just reflects, reticulocytosis or other causes. Spherocytes are non-specific, and of course, there's a bit of inter-observer variability in blood films. Agglutination can be seen in non-clinically significant cold agglutinin, which is an important concept covered in few slides down the line. LDH is sensitive, but it's non-specific. It can be raised in liver damage, or any organ ischemia. And in old days, if you remember, we used to use that as a marker for MI, so heart damage can cause it as well. Raised bilirubin can be seen in a lot of different things as well, as especially liver problems. And haptoglobin is actually now quite relatively a good marker because it can be low in liver disease, but if it's absent, it's almost always hemolysis. So that's actually a good marker for hemolysis amongst all of them. Some hospitals are lucky enough that they can turn over haptoglobin quite quickly, others aren't. And urine dip, as I've said, is a good one for intravascular hemolysis. But as you know, any urine test is difficult to do in a hospital. Urine is absolutely difficult to collect and for logistic reasons, etc. And urine for hemosiderin is quite specific for intravascular hemolysis, but again, it is difficult sometimes to get, and every lab is supposed to do it or have a protocol to send it to a lab that can do it, but yeah, there can be some logistic problems here as well, unfortunately. So having said that, how do we actually diagnose hemolysis then? We say if there are suggestive hemolysis markers in the right clinical setting, that would suggest hemolysis. So the markers are going in the right direction for hemolysis. And some have tried to say, okay, at least two of them, if they are going in the right direction, then in the right clinical setting, we would say there is hemolysis. And that's how ultimately hemolysis is a clinical judgment call. In there, they've actually listed increased ferrocytes, but also elevated urobilinogen. So that's again a bilirubin breakdown product that you can check in the urine. Okay, so that is the basics of how you diagnose hemolysis. But actually, yeah, there's another one. So there are two main mechanisms how hemolysis can happen: extravascular or intravascular hemolysis. Now, extravascular, as the name suggests, is the hemolysis that happens in liver and spleen and is quite controlled because that's how naturally you're supposed to clear the old cells anyway as well. So in hemolysis, this will be in pathogenic hemolysis, this will be happening a bit more increased rate, so to say. Intravascular hemolysis is not normal, and this means that the hemolysis is happening within the blood vessels itself, releasing that toxic hemoglobin, which is free to cause, damage to different organs, especially the kidneys. So in extravascular, toxic hemoglobin is not released in excessive amounts. Intravascular, you will have lots of toxic hemoglobin released, and the one that's unbound above haptoglobin's capacity will like to cause kidney damage. So that's not good. So you do see kidney damage and lots of different intravascular hemolysis causing conditions like PNH or even sickle cell and acute hemolytic transfusion reactions, for example. Sorry, is there a question or just background noise? Sorry. Yeah, so urine color is usually okay in extravascular hemolysis. It can be a bit dark, but in intravascular hemolysis, and this is very characteristic and very specific, and this has to be asked whenever you are suspecting hemolysis because this can hint you towards intravascular. The patient would have change in the color, which is sometimes pinkish, reddish, or dark, very dark, even Coca-Cola urine. As you know, say in PNH, especially early morning, they can have dark urine. But this can be intermittent, so you really have to ask them thoroughly about it. But this is quite a good question to ask. Haptoglobin will be low in extravascular hemolysis as well because some hemoglobin is still being released, and then that would be cleared up. But in intravascular, it will be very low. Hemoglobinuria is absent in extravascular hemolysis, but it's present in intravascular, as I've said, in acute phase. And hemosiderin is present in the chronic phase of intravascular hemolysis. Of course, it's absent in the extravascular version. So that is all about the basics of how do you diagnose diagnose hemolysis as such, and how do you try to differentiate intra versus extra. Any questions up till here? If they are, happy to take. Otherwise, we'll move on to more complex things in a bit.
Coming up next in the series on autoimmune hemolysis.
Thank you for watching. Stay tuned for more.